I have the great pleasure of introducing our next speaker for today's event. So we have Dr. Casey Taft joining us. Dr. Taft is a psychologist at the National Center for PTSD in the VA Boston Healthcare System and professor of psychiatry at the Boston University School of Medicine. Dr. Taft was the 2009 Linda Saltzman Memorial Intimate Partner Violence Research Award winner from the Institute on Violence, Abuse, and Trauma. He has served as principal investigator on several funded grants focusing on understanding and preventing intimate partner violence, including multiple randomized controlled trials and implementation studies of the Strength at Home intervention programs, of which he is the primary developer. He has overseen the full implementation of his Strength at Home programs across the VA healthcare system, the largest healthcare system in the United States. So we're so glad to have you join us, Dr. Taft.
Thanks so much, Kathy. And hi, everyone. It's great to be with you. I am going to be speaking very fast for this half-hour presentation. Then we'll do some question and answers after that. This normally can be up to a 3-hour talk. So we're doing this in 30 minutes. So I'll be talking a little bit quickly. So yeah, I'm going to be talking about the Strength at Home program that I and my team have developed over the years. As was just mentioned, this is a program that's used in the VA, and we're also doing a lot of work using this outside of the VA in civilian contexts, and we have a lot of clinical trials and implementation projects happening right now. So first, what I'm going to do is talk a little bit about the kind of theoretical underpinnings for the program. More specifically, I'm going to talk about how trauma may contribute to risk for engaging in partner violence, because Strength at Home is a trauma-informed program where we consider the role of trauma throughout the program. So it can be helpful to think about why does prior trauma put somebody at such high risk for engaging in partner violence? So I don't see the usual arrows here. Oh, here we are. Okay. So one of the earliest models that was put out there to explain this link between trauma and violence was developed in military service members and veterans through a model called the survival mode model. The idea behind the survival mode model is that service members, when they're in a dangerous area such as a war zone, they learn to go into survival mode, meaning they're extremely aware, hyper aware of their environment and their surroundings. They will notice threats that other people don't see. They have this heightened sense of vigilance in the war zone that helps them perceive threats that may be life-threatening to them or to others. So they're in this survival mode. They perceive threats that others don't see, which is adaptive when you're in that war zone. And it's also applicable to civilians who live in violent areas, folks who are incarcerated, right, where you have to be in survival mode, be constantly on edge. It helps you in that situation, but then when they return home, because of their trauma exposure and life threat that they've dealt with, they're more likely to perceive situations as threatening that aren't truly threatening. So they're more likely to go into survival mode in inappropriate contexts where they perceive unrealistic threats, exhibit an overly hostile appraisal of events, and overvalue aggressive responses to threats. So after somebody's been through trauma, when somebody's been through severe threat in their lives, this is difficult to turn off these kind of survival mode reactions, and they have this overly heightened sense of threat that can kind of cause problems for them. And this model really fits in with another model that's commonly used to explain aggression among both adults and also children. It's called the social information processing model. What this model says is that we interpret our social world through a series of stages. And when one has a bias or a deficit at one or more levels of social information processing, this can lead to risk for aggression. So the first stage of the social information processing model is the decoding stage. And here is where we're trying to decode other people's intentions. We're trying to determine what's going on in a situation. When somebody has experienced trauma, just as with the survival mode, we're more likely to assume the worst in other people during this decoding stage. We may have overly hostile attributional biases that may make us assume that other people want to do us harm, and we respond negatively and aggressively in those situations. So there's a lot of research showing that this happens with kids who come from abusive homes. When they go to school, they assume their peers aren't on their side or are out to get them, and they get into fights and have problems with aggression in school. The same kind of thing with adults. So in the work that we do with these clients, we try to help them recognize their negative perceptions, their overly negative attributions regarding other people, and try to help them view others in a less negative way, being less in that kind of survival mode. The next stage of social information processing is called the decision skills stage. Here is where the person is generating responses to deal with a challenging situation. And people who have problems with violence, people who have trauma histories, often have difficulties generating nonviolent responses to deal with conflict situations. So what we do in our program is we teach them more assertive, pro-social responses to deal with these challenging situations. The last stage is the enactment stage. Here's where the person is enacting the behavior that they've picked. And in Strength of Home, we do a lot of skills training because a lot of folks who engage in violence have a lack of skills to enact more pro-social behaviors. So we teach a range of skills, just like other abuser interventions teach. This is just another way to look at this trauma-informed social information processing model with the 3 stages of social information processing, and also how various other risk factors for violence may map onto this model. So this is really an integrative model in that it brings together all of these other risk factors and ideas for understanding violence together under kind of one umbrella. So for example, power and control, I'm sure many of you are familiar with power and control models for explaining problems with partner violence. And in this model, power and control is one factor that contributes to negative decoding of conflict situations. As part of this model, an important part of the model is PTSD. So when we're talking about that link between trauma and violence, it's really important to think of PTSD because PTSD is a very strong risk factor for violence. Research shows that when a veteran, for example, has PTSD, they're at 3 times greater risk for engaging in partner violence than when the veteran doesn't have PTSD. And what's interesting is that research shows that when we're talking about service members, when they don't have PTSD, they look exactly like civilians in terms of their level of risk for violence. But when the service member has PTSD, again, they're at just about 3 times greater risk for violence. So PTSD is a very strong risk factor for violence. We've published a meta-analysis where we summarize all of the research on this topic and found that overall PTSD is strongly related to risk for both physical and psychological abuse. And this relationship holds up regardless of whether we're talking about civilians or veterans or service members, men, women, et cetera. So this is kind of a universal relationship that when one has PTSD, they're at greater risk for violence. Now, in our program, we're very clear. We never talk about how PTSD causes the violence, right? Ultimately, everybody's responsible for their behavior. We make it really clear that regardless of what problems you're dealing with or your trauma histories, we're all ultimately responsible for our behavior. But it is very helpful to help our clients understand their own trauma better and how that contributes to how they learned some of their problem behaviors that they have. So in order to kind of understand why PTSD is such a strong risk factor for partner violence, it can be helpful to look at the different symptoms of PTSD. So when we disaggregate the symptoms of PTSD and see which of the symptoms are most strongly linked to that risk for violence, overall, we find that re-experiencing symptoms, while they're very distressing for the client, they're often not a strong predictor of violence. So re-experiencing symptoms involve intrusive thoughts and nightmares, flashbacks, those kinds of events that are reminders of the trauma. Again, they're distressing, but they don't tend to lead to violence. Similarly, avoidance and numbing symptoms, avoiding reminders of trauma or feeling emotionally numb or disconnected from others can be very harmful for relationships, but they don't tend to predict violent behavior. What the research shows is that it's those hyperarousal symptoms of PTSD that are, did I just freeze? It looked like I froze a little bit. Research shows that it's those hyperarousal symptoms of PTSD that are most strongly related to that risk for violence. So hyperarousal symptoms refer to those kind of fight or flight symptoms, those survival mode symptoms where the person is constantly on guard and constantly on edge. They have that heightened sense of hypervigilance where they assume that others may want to do harm to them. So this all kind of is consistent with the survival mode model, the social information processing model, that when we're on guard and on edge and really highly hypervigilant, and in that kind of survival mode, this may increase our risk for aggressive behavior. We've done some research at the VA where we've kind of tested this model. So we've not only tested our strength of home programs, but we also test the model that it's based on. So this kind of schematic here was taken from a study or a couple of studies we did at the VA, where we wanted to look at how hyperarousal symptoms contribute to negative ways of thinking, which influence risk for partner aggression. So we used a paradigm called the articulated thoughts and simulated situations, where we have somebody come into the lab, we give them a set of headphones, and we play different couple scenarios for them that is intended to evoke anger in the person listening to them. We ask them to verbalize their thoughts out loud. Then those thoughts are coded into social information processing biases. So what people say is coded into kind of different categories to determine if they are kind of engaging in biased processing where they're assuming the worst, they have hostile attributional biases and that sort of thing. And what we found was when we look at returning veterans, that when they have these higher hyperarousal symptoms, this predicts these negative ways of thinking, which in turn predicts that risk for partner aggression. So this provided some validation of this social information processing model and in particular, how PTSD hyperarousal symptoms may be playing a role. This was another study we published many years ago where this was published in the Journal of Abnormal Psychology. A lot of circles and arrows, way too many circles and arrows here. But what's most important is what's circled in the orange. This was a study of civilians of a large sample of domestic abusers. Amy Holdsworth Monroe, who was at Indiana University at the time and had done a lot of really great research looking at perpetrators of violence, she had this large data set of court-mandated domestic abusers. And I asked her if we could look at her data because she had gathered data on PTSD and social information processing and violence in civilians. And to that point, all of our research had been done with veterans. So we wanted to look at these relationships in civilians. And essentially what we found was we found the same relationships in civilians that we had been finding for veterans, that when civilians have PTSD, they have this heightened risk for going into that kind of survival mode and having these negative interpretations of others, which increases that risk for violence. In strength at home, and when we're thinking about the relationship between trauma and violence, I think it's really important that we don't just specifically focus on PTSD, because many of our clients don't have PTSD. They may not have any diagnosable problems at all, but pretty much all of the clients that we work with will tell us that after going through a significant trauma, they don't see the world in the same way that maybe they did before their trauma. It may affect their ability to trust other people. It may affect their self-esteem, how they feel about themselves. It may lead to kind of conflicts related to power and control. It can lead to guilt and shame. All of these problems that may underlie trauma responses may also have negative impacts on relationships. So that's why we think it's important to help our clients really think about these core themes that may underlie their trauma that contribute to some of their problems and may be risk factors for abuse. And just to go through them really quickly in the sake of time, trust. Virtually all of our clients will describe having difficulties trusting other people because of things they've been through in the past. Their trauma may have been caused by someone who was supposed to be trustworthy. Maybe they may feel they can't trust anyone or that others are out to hurt or betray them. And these feelings of mistrust can carry over into relationships and often can lead to controlling behavior. If you don't feel like you can trust your partner, our clients may be more likely to try to control their partner, try to prevent their partner from hurting them in some way, prevent their partner from leaving them or cheating on them. So you see a lot of those kind of coercive control behaviors start to occur when there is a lack of trust in these relationships. Self-esteem. Many of our clients may unfairly blame themselves for trauma they've experienced, which can affect their low self-esteem. And we know that when folks have low self-esteem, they may feel more insecure in the relationship and again begin to control their partners more. They may engage in aggressive behavior to try to control their partners and to try to make sure their partner doesn't feel a lot better about themselves than the client feels about themselves. So this often leads to escalation of abusive behavior. Exposure to trauma may contribute to profound sense of powerlessness from a trauma perspective. And when our clients feel more powerless, this may lead to use of more power and control kind of behaviors in relationships. Our clients may, because they feel so powerless, may try to control those who are closest to them, including relationship partners. If we're talking about a military population, this is also something we have to consider in terms of how service members or veterans have been taught to communicate from a power and control perspective, because oftentimes service members are taught, one person's always giving the orders, the other person's always following the orders, one person outranks the other and is in charge, right? And in relationships, we know things, it doesn't really work like that, right? And what folks have been learned in terms of communication and power and control in the military may not translate very well to good communication at home. So sometimes we have to really kind of help our clients unlearn what they may have learned in the military. Shame is also a very relevant risk factor. Clients may have experienced shame related to trauma they've experienced. Some theorists have argued that aggression may represent a maladaptive effort to avoid shame and associated feelings of weakness, inferiority, and worthlessness. So rather than really working through their shame, which is such an aversive emotion, one of the most negative emotions we can experience, rather than really processing that shame, they redirect those feelings onto others, kind of project these feelings onto others in the form of aggressive behavior. Shame is also really relevant for the work we do in our program because it often hinders responsibility taking. If our clients are concerned that we'll be shaming them in the program, or if they feel a lot of guilt and shame for their abuse, they may present to us really denying and minimizing their abuse, engaging in victim blaming. So if we can have our clients openly talk about their feelings of shame, oftentimes it breaks down some of those barriers for them taking greater responsibility for their abuse. Okay, so let's shift gears a little bit and talk about partner violence intervention. The reason that we developed Strength at Home about 18 years ago or so was because essentially there was nothing that had been shown to be effective at the time. If we're talking about a military population, even to this day, no other program has been shown to be effective through clinical trials with a military or veteran population. And even in the broader literature, reviews and meta-analyses that summarize all of the research show very little effectiveness of abuser intervention programs in general. One of the most, recent and highly cited meta-analyses that looked at this showed that those receiving abuser interventions average only a 7% reduction in arrests relative to untreated groups. So very little reduction in violence recidivism for those who get court ordered to these kinds of programs. And when studies actually use survivor reports or victim reports, which is really the gold standard, if you want to know if abuse is occurring, you have to talk to the survivors. When studies incorporate the survivor perspectives, they actually show no significant reductions in abusive behavior for those who receive these programs. And this is a huge problem because 500,000 men are mandated to over 2,500 programs every year in the United States, to programs that really we don't really have good evidence that they're effective. So it's a huge safety concern, obviously. And we have to do a lot better about kind of implementing more effective programs for those who are mandated to receive these kinds of interventions. And that's really why we developed Strength at Home. Also, just some other limitations of existing interventions. Some may not be trauma informed. They may ignore psychiatric factors that I already talked about. Many are strictly psychoeducational. So it's just like teaching a class, but we know our clients need something much more penetrating, really to get to the heart of their abusive behavior, how they learn these behaviors, their core issues, their core themes that may be affected by their trauma histories. Many programs are very large and impersonal, which makes it really difficult for folks to really kind of develop the insights they need to develop and really kind of dig a little bit deeper to understand their problems. So let's talk a little bit about Strength at Home. This was a program initially developed through funding from the Department of Defense and the VA. Originally, this was funded to be a model program for partner aggression in service members and veterans. In the past 10 years or so, we've been also focusing pretty heavily on civilians. And now we use the same exact manual with veterans and service members and civilians, because as I talked about earlier, really trauma and social information processing, trauma operates very similarly regardless of the population we're talking about. So, the program works the same in veterans as it does in civilians. And our clients are very much the same across these different populations. So more recently, we've done evaluations with civilians. We have 2 ongoing clinical trials with civilians right now in the US. There's another study that just finished in Israel where we trained Israeli providers in Strength at Home. And we showed that those who receive Strength at Home in Israel do a lot better than when they do the usual programs that they do there. We haven't published that yet, but we're kind of in the process of analyzing the data now. So the program is for clients who've engaged in physical or psychological partner aggression. These are relatively small closed groups, meaning that everybody begins and ends together. We use closed groups rather than rolling admission groups because for a couple of reasons. One is from a trauma perspective, group members really bond and connect to each other. And they also go through kind of different stages of readiness for change, where at the beginning, we're going to assume that they're going to be lower in their readiness for change. And the program really works to increase their motivation, enhance their connections with each other, and get them to take greater responsibility early on in the program so we can see greater change as we're kind of implementing the program. The program is trauma informed, and it's psychoeducational and therapeutic. So we, of course, teach things, but it's also very therapeutic. And it's been informed by interventions for both violence as well as trauma-related problems. So in my training and background, I've worked in the violence field, I've worked in the PTSD and trauma fields. So I kind of melded these different streams of intervention and brought together some of the best experts in these different areas when we were developing Strength at Home. We do reach out to partners before and after our clients start the program and complete the program. With these partner contacts, we go over safety planning with the partners or the survivors. We provide hotline numbers. We provide them referrals. We go over safety planning and just generally kind of linking them with sources of support and assistance. We also want to get their perceptions of any abuse that may have occurred to help us get feedback on the program. This is the general structure of the program. We begin with more motivational strategies, some basic psychoeducation on what abuse actually is, the impact of trauma on those core themes I mentioned earlier. Then we move up more to kind of how to de-escalate conflict. We teach higher level coping strategies and then communication skills through the rest of the program. These are the initial 12 sessions of the program. This is the base program. We also do have stages 2 and 3, but this is really the main program that everybody receives. So early on, like I said, we use motivational strategies. We do motivational interviewing with our clients. We do a pros and cons exercise to help them recognize the need to change. Here we provide basic education on what abuse is, how trauma may impact relationships. We go over those core themes. We have all of our clients develop goals for the program in the first session and continue to have them revisit their goals. Sessions 3 and 4, here we talk more about recognizing anger, as early as possible, a lot of self-monitoring of how they're handling conflict situations. There's a heavy focus on assertiveness training, teaching timeouts to de-escalate situations. Sessions 5 and 6, here we start to get more into the survival mode, have our clients pay a lot more attention to their thinking, their survival mode kinds of thinking. We also go over stress and relaxation training. And the last several sessions are about communication, helping them understand how they learn to express anger and other emotions, how to listen better, how to give an assertive message, how to better express feelings, and avoid communication traps that our clients may fall into. We have a stage 2, an additional 8 weeks after stage 1 that many of our clients will do. And this gets more into those core themes. It gets more into trauma than stage 1. Stage 1 does cover trauma. It's all trauma informed, but stage 2 gets more in depth into some of those core themes. Stage 3 is more focused on relapse prevention. We also have a couples version of our program that folks may do after they do the regular program. They may do the couples program, or the couples program may be appropriate for some couples where they have lower levels of aggression. They're not court ordered. They're coming in looking for couples therapy. This is just generally what the structure looks like. Every week we go over practice. We have them do in-session practice. We teach new skills. So for about the 4 or 5 minutes we have left, I'm going to kind of rifle through the research we've done in the program. This is one way that this program is very different from other programs, and that we've been researching this program for about 18 years. So we've gathered more data on this program than just about any other program that's out there. This was our first study that we did with military veterans, published in the Journal of Clinical Psychiatry. This was a study funded through the Department of Defense. This was a sample in the VA healthcare system. 135 folks were either randomized into strength at home, or they received other therapy at the VA, either individual therapy or substance use treatment or anger management, that sort of thing. 59% of the sample was court ordered. And these are what the main results look like. So these bars are referring to violence, whether the person had engaged in violence. So at baseline, based on reports from the veteran and their partner in both strength at home as well as enhanced treatment as usual, just about everybody had some violence history. But then when we get to post-treatment, we see that violence recidivism in strength at home is about half as what it is in treatment as usual. So essentially, we reduced violence recidivism in half for those who receive strength at home. The rates continue to be lower at the 3-month follow-up. We also showed stronger reductions in psychological abuse for those who got strength at home, greater reductions in coercive control behaviors. These are behaviors where the veteran is telling the partner where they could go or what they could do, going through their phone, making them feel guilty for spending time with other people. Strength at home is very effective in reducing those kinds of behaviors. We published a number of follow-up studies where we looked at additional time points. So this was one follow-up study where overall we found that when we continued to follow this sample, that physical aggression was 56% less likely for those who received strength at home, and folks seemed to benefit equally well whether they had PTSD or not. We published another study where we looked at something called alexithymia. Alexithymia refers to one's ability to identify and express their feelings. What we found was that those who did strength at home got much better at reducing alexithymia, so they got better at dealing with their feelings than those who didn't get strength at home. This is the map where we've implemented strength at home. So we've implemented strength at home at almost all the VA hospitals across the country. So these red dots are where there's a VA hospital where strength at home has been implemented. So we've trained virtually all of the VAs, 163 out of 166. We have 67 expert trainers in the program spread across the country. We've trained over 1,500 clinicians in the VA. And we've seen almost 6,000, it may be over 6,000 by now, 6,000 veterans have been enrolled in these groups. We see about 1,800 a year. I think this number is increasing over time. So a lot of folks in the VA are receiving strength at home. Recently, we published a study in JAMA where we looked at some of the outcomes from this VA implementation. We looked at over 1,700 veterans and basically found reductions in the number of types of aggression folks engaged in. We're also finding reductions in PTSD symptoms. So even though we don't claim strength at home as a treatment for PTSD, their PTSD symptoms do decrease when they get strength at home. Their alcohol problems also go down. And folks report very high satisfaction with the group. So even though 60% of these folks were court ordered, by the time they get to the end of the program, when we ask them if they would recommend the program to a friend, 82% said yes, definitely to this question. 17% said yes, I think so. So adding those numbers up, we have 99% saying yes, they would recommend the program to a friend. Similarly, very high percentage, 98% say that the program helped them deal more effectively with their problems. We found the program works equally well if we're delivering it in person or virtually. In fact, the virtual delivery the results were slightly better than what we had found previously for in person. So significant reductions in physical and psychological abuse, coercive control, PTSD symptoms, and alcohol problems. Just really quickly looking at civilians, I'm going to go through it quickly because the data are essentially the same, whether we're talking about veterans or civilians. This was a small study funded through the National Institute of Mental Health. These were civilians in Rhode Island, inner city Rhode Island, all of whom were court ordered. 87% identified as racial ethnic minorities. All were low income. This is a severely violent sample. 73% had engaged in very severe physical aggression. And basically, we found similar results. So strong reductions in physical and psychological abuse, strong reductions in another form of emotional abuse, significant reductions in PTSD symptoms and alcohol use problems, very high rates of program satisfaction. So again, this is 100% court mandated sample, inner city Providence, Rhode Island. 100% said yes a great deal to the question of whether the program helped them deal more effectively with their problems. So whether we're talking about veterans or folks, in civilian, inner city settings, it's nearly uniform, positive reports on how effective the program was for them. Recently, we've been doing a large implementation in 3 different counties in New York State. So we've gathered data on that as well. Again, the data are pretty much the same as what I've been showing, strong reductions in partner aggression. Alexithymia went down. So in this civilian sample, they get much better at dealing with their feelings, reductions in PTSD symptoms and alcohol problems. And again, very high program satisfaction ratings. This is our website. If anybody's interested in reading any of the studies, you can see all the PDFs in the resources tab here. And if any of you are interested in doing a training, you can contact me through the contact link here. I do trainings every few months to train providers in the program. So with the time we have left, we could take some questions. I saw there were a lot of comments, which is great in the chat. Let's see. I don't know, Kathy, if you want to read them to me or if I should kind of
Yeah,
go through them myself.
sure. Either way, I can read them off. Yeah, we have a couple of questions. First one, statistically, does the prevalence for the use of IPV for veterans with PTSD differ for male and female veterans? Were those that experience IPV, or were those that experience IPV generally higher for females? That's a question.
That's a good question. I don't know that there's been a difference between male and female veterans. There has been a slight difference in that PTSD is more strongly related to risk for violence in male veterans than female veterans. So there's still a relationship there for female veterans. If they have PTSD, they are at greater risk for violence, but that relationship is stronger in men. And that may be because men and women may differ in terms of their trauma reactions, where women, when they experience trauma, develop more internalizing problems. They may become more depressed, whereas men have more externalizing problems. They may become more aggressive. So there does seem to be kind of a gender difference there. I'm not sure about an overall gender difference in likelihood for aggression. I don't think I've seen research on that.
Thank you. There was a follow-up question too about can non-VA clinicians also be trained in Strength at Home program? What suggestions do you have for collaboration with community partners to provide Strength at Home or to be a co-facilitator?
Yeah, right. Absolutely. That's why I do the trainings every 3 months. So if you go to the website and reach out to me through there, yeah, that message will come right to me and I'll tell you about our trainings and invite you to one of our trainings. Those are trainings that I lead myself. The ones in the VA are led by our, 67, trainers that we have in VA. But for the civilian providers, I tend to lead those trainings myself.
So there's another question here. Is brain injury specifically assessed or addressed in any part of the program? And this is actually a question I had while listening to your presentation, because I think about,
Mhm.
in terms of potential, in the VA system, a lot of mild traumatic brain injury, specifically in the veterans, but also in terms of thinking about that intersection
Mhm.
brain injury occurring. And to follow up on that, do you assess for that, address for that? And are there alterations to the intervention that might need to be made for somebody who might have some symptoms of brain injury that are also presenting?
Mhm. We do assess for that. That is part of our assessment, but we don't have a different intervention for that. I think I tried to get a study like that funded years ago, but it wasn't funded. But that is something that when we were developing this program, we really did keep that in mind. So a lot of the folks we see have, attentional problems. They have, whether we're talking about brain injury or PTSD or a variety of other problems they may be coming in with, that can really affect their kind of ability to kind of take in and kind of retain and practice some of the things that we're talking about. So when we were developing the program, we really included a lot of repetition of concepts. There's really in Strength Home, there's a handful of basic concepts that we review every week again and again, and we have our group members practice it again and again. And we try to keep it really as simple as we possibly can, rather than throwing the kitchen sink at people and throwing all these concepts at them every week. For many of our clients, if they can kind of get one concept from the group, that could be the difference, between whether they engage in abuse or not, after they leave the program. So that's kind of our general philosophy. But you still want to determine if you think somebody will not be able to benefit, still have to make clinical judgments.
Right. And thinking about too, just the background of your clients that are coming in. So brain injury is a factor, and this is, I think, maybe speaks to one of the other questions that's in the Q&A, thinking about maybe other cultural factors that might intersect in terms of identities of your clients. Are there other
Mhm.
ways in which you might have to think about adjusting the program to address some of those needs?
Yeah, we've written a paper on this. I wrote a paper with Maxine Davis, who's really kind of a leader on that topic in particular. She's developed programs specifically for people of color, and that's kind of her area of research. We talked about how trauma-informed care for this population is really critical, right? And she termed it's more oppression sensitive, right? When to consider people's trauma histories, people's unique experiences, what they've been through in helping them understand themselves better and understanding their violence better. It really is important to consider the role of trauma and people's unique experiences rather than kind of assuming that all people's abuse, is stemming from exactly the same cause, and the same exact risk factors and that sort of thing. Um, we've done a lot of work working with different populations. So I mentioned there's a clinical trial that's finishing in Israel. So we went to the Middle East and we met folks from Israel and Palestine, Russia, Ukraine, like pretty much every population you can imagine. And they were delivering the group, and the group had been translated into all these different languages. That was a really incredible experience where I went out there and I met with all these different providers, and they told me all of the what worked for them and what didn't work for them when they were implementing the program. And it was really extremely helpful. And I took all of that feedback home with me. And I tried, what I ultimately did was I simplified the program even more, to make sure that all of the concepts would be relevant, for all of these different groups, right? So rather than creating, 10 different versions of the program for different groups, we're really focused more on keeping it as simple and basic as possible so it's really inclusive and applies to everybody.
Right. So you have some universal core aspects that would hopefully be applicable and relevant to across
Exactly.
kind of
Right.
groups. Great. I guess there are a couple more questions here. There's a question in the chat. Understand why strength at home methods would help TBI. Would there happen to be any interest in analysis that specifically compares TBI to non-TBI just to verify?
That's a really good idea, actually. Yeah, no, I don't know if we've actually done an analysis like that, but that's a really good idea. that I will talk to my team about because we've looked at TBI before in we wrote a review paper on this many years ago on like biological factors in partner violence, with
Mhm,
TBI being one of them. And it's barely studied at all. And I think
mhm,
partly because there's never really been much of an appetite to look at biological risk factors for violence, right? Because most of the traditional models are power and control based, so there's kind of a reaction to looking at anything biological.
mhm,
But TBI, especially if we're talking about a veteran population, is obviously really important. We've kind of looked at kind of interactions between TBI and PTSD, looking to see how that impacts social information
mhm,
processing. So we've looked at some basic parts of it. And of course,
mhm,
when we experience a traumatic brain injury, it does affect how you take in and process social
mhm,
information. So that is something that we have looked at. We had a small VA grant to look at that. But I don't know that we've looked at how it impacts treatment response. So that's a
mhm.
no-brainer. We should have looked at that by now. So I think I will talk to
Yeah,
my team about that.
getting some great ideas from the community here then.
Yeah, totally. This is
Um,
how it works. Yeah.
this is great to see. We've got some more questions coming in. There in the Q&A, there's a question about how is this program different from a court-ordered PAR partner assault response program?
Mhm. Well, I mean, this is a court-ordered program. So this is a program that's used all across the country for court-ordered people. Um, but I think it's different from your standard program in that it's more trauma-informed, it's more therapeutic. A lot of the standard programs are I would say a little more confrontational, more punitive. That's been a big criticism of them that they don't really take they're not, they don't really take trauma histories into account so much. Um, they're a little bit more like taught like a class rather than something that's therapeutic. So and maybe, I don't know. I mean, I've never led one of these other groups, so I'm only kind of speculating from what I've learned about them and what others say about them. But I think in general, focusing more on positively reinforcing clients, having them understand themselves and their histories better and how they learn their abuse, and essentially not being overly confrontational goes a long way with this population in helping them take responsibility for their abuse.
Excellent, great. Follow up on that. How could this program be used to lower rates of MST?
Lower rates of MST. Um, I don't so we have a couples program, and if you go to our site, you can look at the resources section. We have a paper we recently published, a study we did at Joint Base Lewis and McChord in Washington State. So in our couples program, we did look at the prevention of sexual aggression. We published a couple of papers on this and have found that the couples version of Strength at Home, working with couples in preventing violence, also prevents sexual coercion and sexual aggression in these couples as well. So we did find that in military couples. We also found that it prevented suicidality in military populations. So it seems to prevent, multiple different forms of aggression towards ourselves, towards others, including sexual aggression.
Right. And we've got another question about, I'm wondering if you have looked at people with PTSD, with brain injury, who may have violent behaviors and use different classes of substances, for example, methamphetamines. So another
Mhm.
layer of intersectionality of different
Right. Yeah.
comorbidities or conditions, right? Yeah.
Mhm. We do have one study. We haven't looked a lot at different use of different drugs, but we do have a current clinical trial happening right now where we're using motivational interviewing for alcohol problems and substance use problems for people who are coming into the program, wanting to see if folks do better if we do short motivational kind of interview with them to encourage them to get help for their substance use problems. But we don't specifically address substance use in the material for the program itself. It focuses more on IPV.
Great. We've got one last minute, and I'm going to steal this last minute for a question in terms of, I think this is phenomenal work addressing the preventative side of things, right? Hopefully putting us all out of a job, right? This would be ideal, right? If we didn't have to talk about this topic anymore because the violence is not there. I don't know if we could totally eradicate it, but just speaking to the
Mhm.
importance of your work, right?
Yeah.
What do you see as the future of this work in terms of pushing forward preventative work in this
Yeah.
area?
I think that's a great question, and I really like the way you frame that. I think ultimately, I think what we need is other large healthcare systems. We need this to be more voluntary and not wait until folks get involved with the criminal justice system before we
Right.
address IPV. I think that's one of the other problems with, the way this problem has been addressed in the community. They with, quote unquote batterer programs, like programs that are 52 weeks long, programs that nobody would ever voluntarily participate in, So we have to make this something that people actually want to do, that they want to get help for. So in the VA, we have 40% of folks who come to our programs are coming in on their own because they don't want to have these problems, right? And if we kind of make that more the norm, where folks
Mhm.
address these problems before they start, or before they get worse, I think that will make an enormous difference.
Yeah, absolutely. Great. Well, thank you so much for your time here. I think we're at the end of session. I think we go to a break, although there's one last question that popped in. I don't know if you want, I know we just said we'd end it. There was one last
Mhm.
question about, do you mix women who use violence in the same group with men who use violence? I guess this is
We
talking about
don't.
intervention.
Yeah, we do separate groups for men
Okay.
and women. That's kind of historically what the field has done, and that's what we do too.
Perfect. Great. Thank you so much, Dr. Taft, for your time and sharing with us your work. It's phenomenal. Yeah, I'm looking forward
Thanks
to
so
seeing
much.
more of this.
I appreciate that. Thanks, everyone. Take care.